And we're off to the races. Okay, so now what I want to do is I want to start talking about things that can mimic ST segment elevation, myocardial infarction, or STEMI. One of the most common mimics of STEMI is known as benign early repolarization. Benign early repolarization, one of the most common mimics of ST segment elevation, myocardial infarction. Benign early repolarization. Very common finding. Tends to cause widespread ST elevation. Anytime that you see widespread ST elevation on a 12 lead, you need to be thinking about a STEMI mimic or a STEMI imposter.
Widespread meaning just in different.
Everywhere,
random.
yeah, everywhere. All, yeah, throughout multiple leads and both the right and left side of the heart. Okay, a global myocardial infarction is a fairly rare thing. It's fairly rare to see inferior STEMI, anterior STEMI, lateral STEMI. Okay, that's very rare. It happens, but it's not very common. So you need to be thinking, okay, is there some sort of mimic that causes ST elevation everywhere going on? Okay. This is most common in patients under 50 years old. Okay. You virtually never see this in people 70 and over, and it's more rare in 50 to 70-year-olds. So this tends to be a young phenomena, and it tends to be fairly healthy. It's benign, not generally a problem. It does cause ST elevation, though. But the kind of ST elevation that it causes is known as concave. It causes a concave ST elevation. So, if I enlarge here, okay, and I draw a line let me find one where you have pretty good. There we go. Yeah. All right. So if I draw a line through here, what do you notice?
Wait, why are you going there?
Just through there, where the J point is there.
Oh, okay.
And do you see kind of how it dips down here? That's what we call concave ST elevation, where it kind of has that concave appearance. Because normally, what are you normally used to seeing with ST elevation? Particularly, you know, we're looking at the inferior. You're normally used to seeing something like this, right? Right? Where the ST elevation comes up like that. Well, here I have it kind of slouching down like that, making like a little cave. That's called concave ST elevation. Okay, that potentially tells you that you're dealing with benign early repolarization. Okay, the other thing, of course, is somebody who's young, less than 50 years old. Okay, that tells you something. The other thing is the T wave morphology. You have tall, peaked T waves. Do you see how the T waves look rather tall and peaked? You guys see that okay? And they are asymmetrical. That is a big finding, asymmetrical. So do you see how this side here, the slope of this side is different than the slope of the side on the right? Do you guys see that there?
Yes.
Okay, so you see kind of it slopes up like, well, let me draw. Slopes up like this, and then it's sharper down there like that. So you have this asymmetry to the T wave. Does that make sense? Now you might look at this, and some of you may already know this, but a common cause of tall peak T waves is hyperkalemia. You may look at this and go, oh no, hyperkalemia, this patient's dying, I need to treat. But if you stop and go, wait a minute, what does a T wave look like? And that asymmetry really does point to a benign early repolarization. And if you notice, is the ST elevation very significant here? It's very subtle. It is widespread, but it's not very much. So it's very subtle ST segment elevation. And you also get a characteristic notch that can develop in your J point. So do you guys see this little notching thing that happens right here? You see that there? You can't, there's a little interference here, you can't see it. Can you see the little notch there as well? Okay. So you get that notching in the J point. That is characteristic of benign early repolarization as well. And there are no reciprocal changes, okay, like you have with the STEMI, where you get elevation in some leads and depression in other leads. You don't see that. You just see elevation kind of everywhere. It's kind of subtle. It can have some notching at the J point, and it kind of has this concave appearance to it. When you see that, that all points to benign early repolarization. Basically what happens here is the heart repolarizes just a little earlier than normal. And so what does that do? The T wave kind of happens toward the end of the QRS. And so it kind of blends into the QRS a little bit, and it gives a false appearance of ST elevation. Does that make sense? But the only thing that's going on here is it's just repolarizing just a little early. That's all. It's not a big deal. It tends to be a very normal finding, but it can, you can, if you're not pithy with your ECG analysis, you can mistake it for a STEMI, or you can mistake it for something like hyperkalemia. So this is one of those subtle things that's very common that can throw you off course. Does that make sense? You guys okay with that? Okay, cool. All right, well, let's move right along. So the next mimic is pericarditis. What is pericarditis? Good. Inflammation or infection of the pericardial sac. And as you might imagine, if the entire sac surrounding the heart's inflamed, the findings are going to be pretty much in all of your leads, right? So this tends to produce widespread ST elevation. Now, the good thing is there's going to be a significant history and physical exam. Okay, so when you're talking to your patient, there's going to be generally something in their history that is going to point you in the direction of pericarditis. Okay? And patients will often present with tachycardia. Okay? So they're going to have an elevated heart rate, they're going to have widespread ST elevation. Okay? And they're going to have history, right? They're IV drug use. Maybe they're in a car crash 3 days ago, and the steering wheel hit their chest, or they had some sort of blunt injury. Maybe they had a heart attack a week ago, and this is developing as a result of that. Okay. Now, the ST elevation is often concave, as is the case with benign early repolarization, right? So again, whenever you see concave ST elevation, that should point you to a mimic. There are at least 3 things that I can think of off the top of my head that can mimic, that can cause concave, and we've talked about 2 of the 3 already. We talked about benign early repol and pericarditis. Okay, but this depression is often associated with PR depression. This is not something that you commonly see with a STEMI. And in the history and physical exam, you want to be thinking about infection, immune system things, uremia. What is uremia? What does emia mean? What does emia mean?
Inability of your body to eliminate the uric acid as it.
Okay, you're getting there. So emia means blood, right?
Uric acid in the blood.
There you go. And it literally means urine in the blood, right? So what is uremia? It is the failure of the kidneys. Good. Kidney failure. Right, yeah. And that accumulation can cause irritation of the pericardial sac. And then status post myocardial infarction. So if you've had a STEMI in the past several days, you can get some inflammation that results from the injury or damage to the heart, and then that can cause pericarditis as well. You guys okay with that? So this is typically what we see. We see something that looks like this. So do you see that concave depression there? Kind of how it kind of slopes or caves down in. And look at the P to R segment here. What do you notice? The P to R segment actually falls below that baseline. That's pretty unique, isn't it? This is something we really haven't talked about at this point. So when you put the history and physical exam together with some tachycardia, okay, with concave depression and PR interval depression, that should point you toward the diagnosis of pericarditis. And this is this is something that is treated very differently than STEMI, right? You're probably not going to want to dump a bunch of nitro into these patients. It may not help them, may even hurt them in some cases. Okay, well, move on. Let's give you guys an example of acute pericarditis. All right, so what do you guys notice looking at this? Let's look at 2, 3, and AVF. Okay, so here's my baseline, right? You guys see the baseline here? What do you see? Yeah, so you guys can see the P to R depression here below the baseline. You see some slight elevation, and what does that elevation look like? It has a concave appearance. So that's in 2. Okay, 3, it's kind of subtle, but look at AVF. Again, you've got some P to R, a little bit of P to R depression there. Okay, well, let's move on to V1. What do you see here? Slight bit of elevation. V2, a little bit of elevation there. V3, kind of the same thing there. Let's move on to V4. What do you see here? Definitely elevation. Did you guys agree? There. All right. Look at that. The P to R segment is depressed as well. All right. V5, V6 look the same. So here if we didn't know any better, we would go, oh, wait a minute, the inferior wall is taking a hit, the anterior wall is taking a hit, and the lateral wall. Well, how likely is that? That's kind of an unlikely thing, so you got to step back and go, wait a minute, well, the ST elevation looks concave, and the P to R segments are depressed. That all points you toward pericarditis and away from a STEMI. Does that make sense? Okie dokie. You guys okay there? All right, cool. Next one I want to talk about, we've talked about this already, but that's Wolfe Parkinsons White syndrome. What's Wolfe Parkinsons White? Yeah, it can cause re-entry tachycardias, and it's typically due to an accessory pathway, right? I believe it's a bundle of Kent is a specific pathway, all right? And remember, what does Wolfe Parkinsons White do to our QRS? Yeah, it makes them wide, right? And you have that characteristic delta wave, which can mimic a STEMI. So here we go. Let's put up a 12 lead of somebody with Wolfe Parkinsons White. And if you're looking at this, if you didn't know better, you'd look at the T waves here. See how they're inverted? So you got some T wave inversion here. Looks like maybe there's a little elevation here, and this is lead 2, right? So it could potentially throw you off track, but if we zoom in here, what do you notice? Yeah, that initial slurring of your QRS, and imagine you could put a triangle there. Remember, this is delta, Greek delta, and imagine I could put a triangle there. I could fit a triangle in there. Yeah, so these are delta waves. So this is actually Wolfe Parkinsons White.
Chris, can you go to 2, 3?
Sure.
Are the P waves always going to be that close, or can
Well, here's,
So there'll be more separation.
there may be, there's a P wave there.
Yeah, but I mean,
Yeah.
I'm just saying, is that interval always gonna be?
Not necessarily, yeah. And look how pronounced the delta waves are here, or look here. Look at that, massive delta wave, huh? Good deal. You guys okay with that? Okay. The next mimic that I want to talk about is digoxin. Dig effect. It's actually such a well-known side effect of taking digoxin. We have a name for it, dig effect, digoxin effect. Digoxin results in several changes. All right. The thing you need to be aware of is that these changes do not indicate toxicity or therapeutic use. So you cannot tell if somebody's dig level is too high or too low based on the 12 lead, okay? So people, we just know that if somebody has digoxin in their system, they're gonna have some changes on their ECG, but that doesn't necessarily mean that they're overdosed or underdosed. The classic findings are a prolonged P to R interval. Okay, your P to R interval can get a little long, generally not incredibly long, generally like less than 0.24 seconds, but definitely long enough to where you're in heart block category. And it produces concave ST depression, and it produces a very characteristic ice cream scoop depression. And imagine that, here, imagine that the baseline is kind of like the top of a tub of ice cream, and then you take a scoop of ice cream out with your little ice cream scooper. Imagine, if you can imagine that ice cream scooper coming in and boop, taking a scoop out, okay? And you see this in multiple leads. So this is another one that causes this to occur in many leads throughout the 12 lead. And I just think of Salvador Dali, right? And I don't know if any of you are aware of him or not. He was a painter, and he kind of had this Dali-like mustache. And so I don't know, I wanted to draw that too. So, so if we look at an ECG here, what do you notice? See, I kind of have that flattened, concave, scoop-like appearance. And then look at this segment here. Does that kind of look like that little mustache coming up? Kind of looks like that. If we go back up here, it kind of looks like Salvador Dali's, the side of his little mustache there, right? Yeah, a little mustache. All right, so yeah, very classic we're finding. And let me just show you another example here. So here I have somebody in atrial fibrillation, and what do we know is often used to treat atrial fibrillation? Digoxin, how about that? So what do you see? Do you see ST depression here? Do you see that there? Do you see some SP depression here? Let's see, we see it here in AVL. Little depressed in V2, V5 definitely, V6 definitely, V4. So do we have depression throughout the 12 lead?
Yes.
Yes, in both the right and left side, but what does that depression look like?
Mustaches.
Okay, yeah, you got your little mustache, right? And it has that concave depression-like appearance to it. So you might initially look at this and go, oh no, he's having a non-STEMI or a unstable angina. Wait a minute, what medicines are we on? What's going on here? Oh, okay, this is dig effect. And you can clearly see that we're in AFib if you look at the rhythm strip there. It's very irregular, fibrillatory baseline. You guys okay with that there? Okay. We're looking good. I think that is all the further I want to take you guys today because we have gone over an incredible amount of information. Let's just go ahead and review what we've gone over though today. Okay, so let's just review since we have gone over a lot of stuff. So we started off talking about what? Yeah, we've gone over so much we don't even know it yet.
Yeah, like, wait,
We started off talking about special STEMI, right? What are the two special STEMIs that we focused on this morning?
Posterior wall.
Good, posterior,
oh,
And
like
right
that.
ventricle.
yes,
Right.
good. So we talked about posterior MI. And where would we see posterior MI manifest on a standard 12 lead? Again, I just want to review.
2B4.
Yeah, V1, V3s. And what would you see?
Depression. ST
Yes,
depression.
ST depression that has a positive mirror sign, right? Because if you took that digeffect or that pericarditis ECG that we just looked at, would that pass the mirror test?
I don't know, can we look at, I mean, I'm assuming no, because of
Let's see if I
what
can,
you're asking, but can you flip that upside down?
I can try.
Hot dog.
Does it really look like?
No.
Not really, does it? It doesn't really look like. Yeah, so you see that it is very characteristic, that mirror sign. So if we see that, what do we need to do?
Move
V4, V5, V6 to the back.
V4 becomes V7, good. V5 becomes V8. V6 becomes V9, right? And this is also known as a 15 lead or a posterior. You guys cool with that? Okay. So that was the first special STEMI. And then what was the second one we talked about? There we go, RVI. And what do we generally say? What kind of STEMI is RVI associated with? So if you notice an inferior wall myocardial infarction, a STEMI, what can we do? Good. Yeah, V4R is going to be the most important one, and that is just reflecting V4 where? To the right. All right. You guys good with that?
Yep.
Awesome. Then what do we talk about?
Axis deviation.
Ooh. We talked about axis deviation. All right, so let's just review axis. What is the normal axis?
0 to positive
0 to positive 90. And what leads, let's just do this too. Lead 1, lead 2, lead 3. Okay, QRSs, what do they look like? So up, up, up. You guys go with that? All right. What is a patho LAD? Yeah.
0 to 0.
Right, negative 30
That's
to negative 90 degrees, right? What will that look like? Good. And then we have right axis deviation, which is positive 90, good. 90 to 180. What will that look like?
down.
No.
Down.
Oh, yeah.
Down, up, right? Because it's shifting away from lead 1. Because remember, if I draw my little circle around the heart, lead 1 is at 0 degrees, right? And then lead 2 is at
60.
plus 60, that's 2. Lead 3 is at
120.
right, plus 120. If I have right axis deviation, where is the arrow? It's pointing in kind of in this direction here, right? So it's going to be going,
Down, down, up.
yeah, it's going to be going toward 3, 2, but totally away from 1. So down, up, up. And that makes sense why? All right, good. So down, up, up. And then right shoulder or no man's land or extreme right axis is,
Down.
yeah, what is the,
-90 to -180.
good, so 180 to -90, so it's this in here, right? Yeah, and if the arrow is moving in this direction, it is moving away from all 3 leads. So you're gonna have down, down, down. You guys cool with that? All right, we talked about that. We talked about the different causes associated with the different types of axis deviation. And then finally, that brought us into a discussion about STEMI mimics. And what were the mimics that we've talked about so far today? So benign early repolarization, right? We said it's a normal variation, generally younger people, generally causes a mild, widespread or diffusely spread ST elevation. What does it look like though?
Concave.
Concave,
The J points are elevated.
notching at the J point, good. You guys okay with that? All right, what was the next one we talked about? Pericarditis, what does that look like?
Widespread ST elevation.
Widespread ST elevation,
Concave.
concave as well, but what would differentiate it from benign early repol?
Significant
Oh,
history.
PR.
History and PR depression, right? That's the big significant thing there. Yeah. Okay, what was the next thing we talked about? Wolfe Parkinsons White syndrome. That's the presence of those delta waves, the slurring on the up notch of the Q, or the R wave rather, excuse me. Okay, good. And then finally we talked about the dig effect, good. Now we haven't talked about it yet, but we did talk, I did mention it last week, and that is the presence of a bundle branch block is another big STEMI mimic. STEMI imposter, specifically left bundle branch block. You guys remember that from last week? And at that point, we hadn't had a lot of nuanced 12 lead stuff, right? And so what did I say? What was kind of the guideline that I gave you guys last week?
Treated as a STEMI.
Always or?
If you married it up with the signs and symptoms and your assessment of the patient.
Good. So if your patient has signs and symptoms of acute coronary syndrome and a new onset or a presumably new onset left bundle branch block, you would be pretty well justified in treating that as a STEMI. It's a little more nuanced than that, unfortunately. I'm not going to get into it today, but there is something called Scarbassa's criteria, Scarbassa criteria. We actually use that to examine the ST elevation in patients with left bundle branch block. And we look for different types of what's known as concordant and discordant elevation, elevation that goes along with or against the direction of the QRS complex. And there are different thresholds based on concordant and discordant morphology of the QRS, or of the ST segment compared to the QRS. That we can use. I'm not going to get into it today, but that's just something you want to throw in the back of your mind, that it actually is a little more detailed than just, oh, treat them all like they're having STEMI. There is a little more detailed examination that occurs there. Paced rhythms is another thing we talked about last week. If you have a ventricular paced rhythm, all bets are off. You cannot really rely on the 12 lead to show you anything, the paced rhythm. Ventricular paced rhythm, that is. Okay, I think we're in good shape. So next, Wednesday, huh? So Wednesday, I hope to finish all this, the mimics, And that just will leave us with drug and electrolyte effects. And we will, first thing Wednesday morning, I hope, since we have all of our equipment back, we'll run our scenarios. We'll do both scenarios that morning. First group will go, then the second group will go. We'll run our scenarios, and then we will try to finish up. What we don't finish up, we'll finish up on Monday next week. And then after that, I'll do a review for your guys' final
On Monday?
on Monday. And then on Wednesday, you guys will have your final exam. And there will be a practical component to that as well, but you guys have done so many 12 leads up to this point. I don't think you would probably have any problems running a 12 lead. Would you have problems defibrillating or cardioverting either? Hopefully not at this point. We've done enough of that. So that's where that puts us.
Those are the only three,
Oh, and pacing as well, yeah. And that's it.
I thought there was more.
Is the test gonna be over like strips, just interpret?
Yeah, it'll be strips, 12 leads, some scenario-based stuff as well. This is what you see is going on with the patient. Yeah. Yeah, actually, I think you guys are gonna find it kind of an easy exam. Like I said, this is one of the more laid-back classes, so just enjoy it.
What were you
Relax, have fun.
telling us you were gonna show us that you had on here?
Oh, that was benign. One of you